Hello, today we're going to talk about airway management and mechanical ventilation. Patients in the ICU often need mechanical assistance to maintain a patent airway. We do that by inserting a tube into the trachea, bypassing the upper airway and the laryngeal structures, creating an artificial airway. If the tube is placed in the laryngeal structures, creating an artificial airway. If the tube is placed into the trachea via the mouth or the nose, it's an endotracheal tube. If it goes through a stoma in the neck, it's a tracheostomy. ET intubation is more common in the ICU patients than tracheostomy. It's performed quickly and safely at the bedside. It's a surgical procedure that's performed when needed for artificial airways that are long-term. There's an ongoing debate regarding the timing of a tracheotomy in regard to patients with ET tubes. Research suggests that early tracheotomy at 2 to 10 days may have advantages over delayed tracheotomy, particularly when This slide discusses the indications for an artificial airway, such as an obstruction or apnea, or a patient's inability to protect their airway. That would be something like a head trauma. Another reason might be ineffective clearance of secretions or, of course, respiratory distress. In this slide, you just see T-tube. All the parts are labeled for you, so just take a few minutes and examine this and try to familiarize yourself with it. In oral intubation, the ET tube is passed through the mouth and the vocal cords and into the trachea with the aid of a laryngoscope or a bronchoscope. Oral ET intubation is preferred by a scope or a bronchoscope. Oral ET intubation is preferred for most emergencies because the airway can be secured really fast and a larger diameter tube can be used. A larger bore ET tube reduces the work of breathing because there's less airway resistance. It's easier to remove secretions, perform fiber optic bronchoscopy if needed. There are risks that are associated with oral ET intubation, such as the teeth can be chipped or accidentally removed during the procedure. Salivation is increased and swallowing is difficult. Patients can obstruct the ET tube by sedation, along with a bite block or oral pharyngeal airway may be used to avoid this. The ET tube and the bite block, if used, should be secured separately to the face. Mouth care is a challenge due to the limited space of the oral cavity. Manage this by using smaller or pediatric size oral products for toothbrushing. Intubation, the ET tube is placed blindly. That means without being able to see the larynx. It goes through the nose, then through the nasopharynx, and then the vocal cords. Unless the procedure is emergent, you want to try to get consent. You want to talk to the patient and the caregiver, explaining the reason for the intubation and the procedure if indicated. It's also important to explain that while intubated, the patient will not be able to speak, but that you will provide other means of communication. Tell them the patient's hands may be restrained or in mitts to prevent them from touching or pulling at the airway. A couple of other considerations would be Mambu, whatever you want to call it, available all the time and attached to oxygen. You want suction equipment ready at the bedside, and the patient should have IV access. The BBM should be the kind that has a reservoir that can be filled with oxygen so that you can deliver 100% concentrations. The slower the bag is deflated and in percent concentrations, the slower the bag is deflated and inflated, the higher the O2 concentration will be that you deliver. Assemble and check the equipment to be used. Remove the patient's dentures and or partial plates for oral intubation and give drugs as ordered. Pre-medication varies depending on the patient's level of consciousness as ordered. Pre-medication varies depending on the patient's level of consciousness, nature of the procedure, and the healthcare provider's preferences. For oral intubation, the patient is placed supine with the head extended and the neck flexed. It's called the sniffing position. This position permits visualization of the vocal cords. Before intubation is started, we should pre-oxygenate the patient using the BVM and 100% oxygen for 3 to 5 minutes. Each intubation attempt is limited to less than 30 seconds. Ventilate the patient between successive attempts using the BVM and O2. I is the rapid concurrent administration of both a sedative and a paralytic agent during emergent airway management to decrease the risk of aspiration and injury to the patient. RSI is not indicated in patients who are in cardiac arrest or have known difficult airways. A sedative, hypnotic amnesiac unconsciousness along with a rapid onset opioid to blunt the pain of the procedure. A paralytic drug is then given to produce skeletal muscle paralysis. Monitor the patient's oxygenation status during the procedure with pulse oximetry. After intubation, inflate the cuff and confirm the placement of using the BVM with 100% oxygen. Use an end-tidal CO2 detector to confirm proper placement by noting the presence of exhaled CO2 from the lungs. Place the detector between the BVM and the ET tube and either look for a color change indicating the presence of CO2 or a number. If no CO2 is detected, the tube is in the esophagus and needs to be reinserted. Auscultate the lungs for bilateral breath sounds and the epigastrium for absence of air sounds. Observe the chest for symmetrical chest wall movement. In addition, SpO2 should be stable or improved. If the findings support that you have obtained a proper ET tube placement, you want to connect the tube to a mechanical ventilator and secure per your agency policy. Suction the ET tube in the pharynx and insert a bite block if you need one. Obtain a chest x-ray immediately to confirm tube location, 2 to 6 centimeters above the carina in the adult. This position allows the patient to move the neck without moving the tube or causing it to enter the right mainstem bronchus. At this point, you're ready to use an ET tube securing device. Know what is used in the facility you're working for. If tape is used, you want to clean the patient's skin with mild soap and water. Remove oil from the skin with alcohol and allow to dry. Apply a skin adhesive product to enhance tape adherence. When the tape is removed, a hydrocolloid membrane over the cheeks to protect the friable skin. Secure with adhesive tape as shown here. Once proper positioning is confirmed with X-ray, record and mark the position of the tube at the lip or the teeth. Usually the 21st centimeter mark for women or the 23rd centimeter mark for men, or the nose. Cut excess tubing to reduce dead airspace according to your hospital policy. Obtain ABGs 15 to 30 minutes after intubation to determine baseline oxygenation and ventilation status. ABG values are reviewed and used to guide oxygenation and ventilation changes. Continuous pulse oximetry provides data regarding arterial oxygenation, and end-tidal CO2 monitoring provides data related to ventilation. Continuously monitor the patient with ET tube for proper placement. If the or enter the esophagus or the right mainstem bronchus, thus ventilating only the right lung. Maintain proper ET tube placement by placing an exit mark on the tube. Confirm that the mark remains constant while at rest and during patient care, repositioning, and transport. Observe for symmetric chest wall movement and auscultate to confirm bilateral breath sounds. If the ET tube is not positioned properly, it is an airway emergency. If this occurs, stay with the patient. Maintain the airway, support ventilation O2, and call for appropriate help to immediately reposition the tube. If a dislodged tube is not repositioned, minimal or no O2 is delivered to the lungs, or the entire tidal volume is delivered to one lung. This places the patient at risk for pneumothorax. The cuff is an inflatable, pliable sleeve encircling the lower outer wall of the ET tube. The high-volume, low-pressure cuff stabilizes and seals the ET tube within the trachea and prevents escape of ventilating gases. However, excess volume in the cuff can damage the tracheal mucosa. To avoid this, inflate the cuff with air and measure and monitor the cuff pressure. To ensure adequate tracheal perfusion, maintain the cuff pressure at 20 to 25 centimeters of water. Measure and record cuff pressure after intubation and on a routine basis, like every 8 hours, using or the minimal leak technique, the MLT. The steps in the MOV technique for cuff inflation are as follows. For mechanical ventilated patients, place a stethoscope over the trachea and inflate the cuff to MOV by adding air until no leak is heard at peak inspiratory pressure, which is the end of ventilation. For the spontaneously breathing intubated patient, inflate until no sound is heard after a deep breath or after inhalation with a BBM. The MLT is similar, except a small until a leak can be auscultated at peak inflation. Both techniques aim to prevent the risk of tracheal damage due to high cuff pressure. The use of continuous cuff measurement is being studied. Use a manometer to verify the cuff pressures between the 20 and 25 centimeters of water and record the cuff pressure, and the volumes of air are needed to keep the cuff inflated. The cuff could be leaking, or there could be tracheal dilation at the cuff site. In these situations, notify the healthcare provider. So a couple things worth noting. First of all, do not routinely suction a patient. Regularly assess the patient to determine if suctioning is needed. Visible secretions in the ET tube, a sudden onset of respiratory distress, suspected aspiration of secretions, increase in respiratory rate with or without sustained coughing, and a sudden decrease in SpO2. Other signs that indicate that a patient might need suctioning include an increase in peak airway pressure, and auscultation of adventitious breath sounds over the trachea or the bronchi. This is a picture of a closed tracheal suction system. These 6 systems have become very popular and are used in almost every ICU. That you go to because they allow suctioning while reducing the risk of contamination from outside pathogens. They also reduce the colonization within the unit, and they protect the caregiver from exposure. Potential complications associated with suction: hypoxemia, bronchospasm, increased intracranial pressure, dysrhythmias, hypertension, hypotension, mucosal damage, pulmonary bleeding, pain, and infection. Tracheal mucosa damage may occur because of excessive suction pressure, catheter insertion, and the suction catheter itself. Blood streaks or tissue shreds and aspirated secretions may indicate the mucosal damage has occurred. Mucosal damage increases the risk of infection and bleeding, particularly if the patient is receiving anticoagulants. When an oral ET tube is in place, the patient moisten the lips, tongue, and the gums with saline or water swabs to prevent mucosal drying. Proper oral care provides comfort and prevents injury to the gums and plaque formation. Perform oral care using pediatric or adult soft toothbrushes at least twice a day by gently brushing to clean and remove plaque. Use oral swabs with a 1.5% hydrogen peroxide solution every 2 to 4 hours. Use a 0.12% chlorhexidine oral rinse twice daily. Apply a mouth moisturizing. Suction oral cavity and pharynx frequently. Frequent assessment and meticulous care are required to prevent skin breakdown. Reposition and retape the ET tube per the agency policy and as needed to prevent skin breakdown. For the nasally intubated patient, remove the old tape and clean the skin around the ET tube with the saline soap, gauze, and cotton swabs. For the orally intubated patient, remove the bite block if present and the old tape. Provide oral hygiene and then reposition the ET tube to the opposite side of the mouth. Replace the bite block if appropriate and reconfirm proper cuff inflation and tube placement. Secure the ET tube again per the agency policy. 2 staff members should always perform the repositioning procedure to prevent accidental ET tube dislodgement. Monitor the patient for any signs of respiratory distress throughout the procedure. Observe for signs of unplanned extubation. This can be a life-threatening event. Should an unplanned extubation occur, stay with the patient and call for help. Interventions are aimed at maintaining the patient's airway, supporting ventilation, example, manually ventilating the patient, with the bag valve mask and O2, securing the appropriate assistance to immediately reintubate the patient if necessary, and providing psychological support to the patient. Okay, so now we're going to leave intubation and move on to mechanical. It's the process by which the FiO2, it's 21% for room air or more, is moved in and out of the lungs by a mechanical ventilator. Mechanical ventilation is not curative. It is a means of supporting the patient until they recover the ability to breathe independently. It can also serve as a bridge to long-term mechanical ventilation or until a decision is made to withdraw ventilatory support. The two major types of mechanical ventilation are negative pressure and positive pressure ventilation. Negative pressure ventilation involves the use of chambers that encase the chest of the body and surround it with intermittent subatmospheric or negative pressure. The iron lung was the first form of negative pressure ventilation that developed during the polio epidemic. Intermittent negative pressure around the chest wall causes the chest to be pulled outward. This reduces the intrathoracic pressure. Air rushes in via the upper airway, which is outside. The machine cycles off, allowing chest retraction. This type of ventilation is similar to normal ventilation in that decreased intrathoracic pressure produces inspiration and expiration is passive. Negative pressure ventilation is delivered by non-invasive ventilation and does not require an artificial airway. B is the primary method used in acutely ill patients. During inspiration, the ventilator pushes air into the lungs under positive pressure. Unlike spontaneous ventilation, intrathoracic pressure is raised during lung inflation rather than lowered. Expiration occurs passively as in normal expiration. The two types of PPV are volume ventilation and pressure ventilation. With volume ventilation, a predetermined tidal volume is delivered with each inspiration, and the amount of pressure needed to deliver the breath varies based on the compliance and resistance factors of the patient ventilator system. Consequently, the tidal volume is consistent from breath to breath, but the airway pressure will vary. With pressure ventilation, the peak inspiratory pressure is predetermined. The tidal volume delivered to the patient varies based on the selected pressure and the compliance of the patient ventilator system. Careful attention must be given to the tidal volume to prevent unplanned hyperventilation or hypoventilation. For example, when the patient breathes out of synchrony with the ventilator, the pressure limit might be reached quickly, and the volume of gas delivered may be very small. Mechanical ventilator settings regulate the rate, the tidal volume, the oxygen concentration, and other characteristics of ventilation. Settings are based on the patient's status, such as their ABGs, their ideal body, respiratory muscle strength. Settings are evaluated and adjusted frequently until oxygenation and ventilation targets have been reached. It is important that you check all ventilator alarms and make sure that they are always on. Alarms alert the staff to potential dangerous situations such as mechanical malfunctions, apnea, unplanned extubation, or patient asynchrony with the ventilator. There's a table in your book, table 6511, that you should review. The low pressure limit alarm can be activated for a total or partial ventilator disconnect, loss of the airway, or the ET tube or trach cuff leak. An apnea alarm can be triggered for respiratory arrest, over sedation, change in patient condition, or loss of an airway. A high tidal volume or minute ventilation or respiratory rate alarm can be triggered for patient condition or excessive condensation in the tube. Low tidal volume or minute ventilation alarm can be triggered for a change in the patient's breathing effort, such as the rate or the volume. The patient is disconnected, has a loose connection, or a leak in the circuit. The ET tube or trach cuff has a leak. There's insufficient gas flow. The ET tube or trach cuff has a leak. There's insufficient gas flow. And a ventilator inoperative or low battery alarm can be triggered for a machine malfunction, or if the machine becomes unplugged, there's a power failure or internal battery not charged. Methods by which the patient and the ventilator enter modes. The selected ventilator mode is based on how much work of breathing the patient should or can perform. Workup breathing refers to the inspiratory effort needed to overcome the elasticity and the viscosity of the lungs along with the airway resistance. The mode is determined by the patient's ventilatory status, respiratory drive, and ABGs. With assist control ventilation, or ACV, the ventilator delivers a preset tidal volume at a preset frequency. When the patient initiates a spontaneous breath, the preset tidal volume is delivered. The ventilator senses a decrease in intrathoracic pressure and then delivers the preset tidal volume. The patient can breathe faster than the preset rate, but not slower. The mode has the advantage of allowing the patient some control over ventilation while providing some assistance. ACV is used in patients with a variety of conditions, including neuromuscular ischemia and acute respiratory failure. In the ACV mode, the patient has the potential for hyperventilation. The spontaneously breathing patient can easily become overventilated, resulting in hyperventilation. If the volume or the minute rate is set too low and the patient is apneic or weak, the patient can become hypoventilated. And monitoring of ventilatory status, including respiratory rate, ABGs, SpO2, SVO2, and ScVO2. It's also important that the sensitivity or amount of negative pressure required to start a breath is appropriate for the patient's condition. For example, if it's too difficult for the patient to begin a breath, the work of breathing is increased and the patient may tire. This is often referred to as riding the ventilator. They also may develop ventilator asynchrony, which is when the patient fights the ventilator. With synchronized intermittent mandatory ventilation, or SIMV, there's a preset tidal volume at a preset frequency in synchrony with the patient's spontaneous breathing. Between ventilator-delivered breaths, the patient can breathe spontaneously through the ventilator circuit. Thus, the patient receives the preset FiO2 during the spontaneous breaths, but self-regulates the rate and the tidal for those breaths. SIMV is used during continuous ventilation and during weaning from the ventilator. It may be combined with PSV, which we'll talk about later. Potential benefits of SIMV include improved patient ventilator synchrony, lower mean airway pressure, and the prevention of muscle atrophy as the patient takes on more of the work of breathing. SIMV has disadvantages. If spontaneous breathing decreases when the preset rate is low, ventilation may not be adequately supported. Only patients with regular weaning with SIMV demands close monitoring and may take longer because the rate of breathing is gradually reduced. Patients being weaned from SIMV may have increased muscle fatigue associated with spontaneous breathing efforts. With pressure support ventilation, or PSV, positive pressure is applied to the airway only during inspiration and is used in conjunction with the patient's spontaneous respirations. The patient must be able to initiate a breath in this modality. A preset level of positive air pressure is selected so that the gas flow rate is greater than the patient's inspiratory flow rate. As it initiates a breath, the machine senses a spontaneous effort and supplies a rapid flow of gas at the initiation of the breath and a variable flow throughout the breath. With PSV, the patient determines the inspiratory length, tidal volume, and respiratory rate. Tidal volume depends on the pressure level and the airway compliance. Positive expiratory pressure, or PEEP, is a ventilator maneuver in which positive pressure is applied to the airway during exhalation. Normally, during exhalation, airway pressure drops to near zero and exhalation occurs passively. With PEEP, exhalation remains passive, but the pressure falls to a preset level, often between 3 to 20 centimeters of water. Lung volume during expiration between breaths is greater than normal with PEEP. This increases functional resistance capacity, or the FRC, and often improves oxygenation with restoration of lung ventilation. The mechanisms by which PEEP increases FRC and oxygenation include increased aeration of the patient's alveoli, aeration of previously collapsed alveoli, and the prevention of alveolar collapse throughout the respiratory cycle. By contrast, auto-PEEP is not purposefully set on the ventilator time. Interventions to limit auto-PEEP include sedation and analgesia, large diameter ET tubes, bronchodilators, short inspiratory times, and decreased respiratory rates, reducing water accumulation in the ventilator circuit by frequent emptying or use of heated circuits also limits auto PEEP. In patients with short exhalation times and early airway closures, such as COPD and asthma, setting PEEP above auto PEEP can offset auto PEEP effects by splinting the airway open during exhalation and preventing air trapping. General, the major purpose of PEEP is to maintain or improve oxygenation. The major purpose of PEEP is to maintain or improve oxygenation while limiting the risk of O2 toxicity. FiO2 can often be reduced when PEEP is used. PEEP is generally indicated in all patients who are mechanically ventilated. The classic indication for PEEP therapy is ARDS. PEEP is used with caution in patients with increased intracranial pressure, low cardiac output, and hypovolemia. In these cases, the adverse effects of PEEP might outweigh the benefits. Continuous positive airway pressure, CPAP, restores similar to PEEP. However, the pressure in CPAP is delivered continuously during spontaneous breathing, thus preventing the patient's airway pressure from falling to zero. For example, if CPAP is 5 centimeters of water, airway pressure during expiration is 5 centimeters of water. During inspiration, 1 to 2 centimeters of water, 3 to 4 centimeters of water. In addition to O2, bilevel positive pressure, or BiPAP, provides 2 levels of positive pressure support: higher inspiratory positive airway pressure and lower expiratory positive airway pressure. High-frequency oscillatory ventilation, or tidal volumes, usually 1 to 5 milliliters per kilo of body weight, at rapid respiratory rates, 100 to 300 breaths per minute, in an effort to recruit and maintain lung volume and reduce intrapulmonary shunting. Although HFOV may be a useful mode for patients with life-threatening hypoxia, it has not lung protection in patients with ARDS. Patients receiving HFOV must be sedated and may be paralyzed to suppress spontaneous respirations. All patients must receive concurrent sedation and analgesia if using a paralytic drug. Nitrous oxide is a gaseous molecule that is made intravascularly and participates in the regulation of pulmonary vascular tone. Inhibition of nitrous oxide production results in pulmonary vasoconstriction, and administration of continuously inhaled nitrous oxide results in pulmonary vasodilatation. Administration of nitrous oxide may be given through an ET tube or a tracheostomy or a face mask. Currently, nitrous oxide is used as a diagnostic screening tool for pulmonary hypertension and to improve oxygenation during mechanical ventilation in this patient. Although the use of nitrous oxide does not reduce mortality in patients with ARDS, it may be used in patients with life-threatening hypoxia. Prone positioning is the repositioning of the patient from a supine or lateral position to a prone on the stomach with face down position. This repositioning improves lung recruitment mechanisms. Gravity reverses the effects of fluids in the dependent parts of the lungs as the patient is moved from supine to prone. In this position, the heart rests on the sternum away from the lungs, contributing to an overall uniformity of pleural pressures. The prone position is relatively safe, although nurse-intensive. Supportive therapy used in critically ill patients to improve oxygenation. And as we know, it's been used frequently now with patients with COVID-19. Extracorporeal membrane oxygenation, or ECMO, is an alternative form of pulmonary support for the patient with severe respiratory failure. It is used more frequently in the pediatric and neonatal populations, but is increasingly being used in adults. ECMO is a modification of cardiac bypass and involves partially removing blood from the patient with a large bore catheter, infusing oxygen, removing CO2, and returning the blood back to the patient. Regulation and is a time-limited intervention. A skilled team of specialists, including a perfusionist, is required constantly at the bedside. Let's talk about some complications of positive pressure ventilation. Positive pressure ventilation can affect circulation because of the transmission of increased mean airway pressure to various structures in the thoracic cavity. With increased intrathoracic pressure, thoracic vessels are compressed. This results in decreased venous return to the heart, decreased left ventricular end diastole volume or preload, decreased cardiac output, and hypotension. Mean airway pressure is further increased if we're titrating PEEP to greater than 5 centimeters of water to improve oxygenation. Another complication of PPV is volutrauma. The concept of volutrauma in PPV relates to the lung injury that occurs when large tidal volumes are used to alveolar fractures and movement of fluids and proteins into the alveolar spaces. Patients with ARDS are particularly prone to this, so low volume ventilation rather than pressure ventilation should be used in ARDS patients to protect their lungs. One of the most concerning complications of positive pressure ventilation is pneumonia, or VAP, is a pneumonia that occurs 48 hours or more after ET intubation. It occurs in as many as 27% of all intubated patients, with half of the cases developing within the first 4 days of mechanical ventilation. In addition, patients who develop VAP have significantly longer hospital stays and higher mortality rates than those that do not. In patients with early VAP within 96 hours of mechanical ventilation, sputum cultures often grow gram-negative bacteria such as E. coli, Staphylococcus pneumoniae, Haemophilus influenza. Organisms associated with late VAP include antibiotic-resistant organisms such as Pseudomonas aeruginosa and oxacillin-resistant Staphylococcus aureus. These organisms are abundant in the hospital environment and or the patient's GI tract. They can spread via contaminated respiratory equipment, inadequate hand washing, adverse environmental factors such as poor room ventilation and high traffic flow, and decreased patient ability to cough and clear secretions. Colonization of the oropharynx tract by gram-negative pneumonia. Most hospitals have protocols in place to decrease the incidence of ventilator-associated pneumonia. Guidelines on VAP prevention include minimizing sedation, including daily spontaneous awake trials, SATs, and daily spontaneous breathing trials, use of ET tubes with subglottic secretion drainage ports for patients likely to be intubated greater than 48 to 72 hours, head of bed at a minimum of 30 to 45 degrees unless medically contraindicated, and no routine changes in the patient's ventilator circuit tubing. Prevention also includes strict equipment is touched and after contact with any respiratory secretions. Always wear gloves in contact with the patients and change gloves between activities. Finally, always drain the water that collects in the ventilator tubing away from the patient as it collects. The ABCDEF bundle is an evidence-based practice of providing care that strives to attain an environment in which all patients receiving mechanical ventilation are calm, delirium-free, and are able to express their needs for pain control, positioning, and reassurance. The ABCDEF bundle ensures 1. Assessment, 2. Both SATs and SBTs. 1. Assessment, 2. Both SATs and SBTs are done. 3. Correct choice of analgesia and sedation. 4. Delirium prevention and management. 5. Early mobility. And 6. Family engagement. Feeling safe is an overpowering need for patients. On mechanical ventilation. Work to strengthen the various factors that affect feeling safe. Encourage hope as appropriate and build trusting relationships with both the patient and the caregiver. Involve them in decision making as much as possible. Progressive fluid retention often occurs in PV with PEEP. It's associated with decreased urinary output and increased sodium retention. Fluid balance changes may be due to decreased CO2, which in turn results in diminished renal perfusion. Consequently, renin release is stimulated with subsequent production of angiotensin and aldosterone. This results in changes in the thorax are associated with decreased release of atrial natriuretic peptide, which also causes sodium retention. Mild water retention is also associated with PPV. There is less insensible loss via the airway because of ventilated delivered gases are humidified with body temperature water. In addition, as part of the stress response, release of antidiuretic hormone, and cortisol contributes to sodium and water retention. Patients receiving PPV are stressed because of serious illness, immobility, and/or discomforts associated with the ventilator. This places the ventilated patient at risk for developing stress ulcers and GI bleeding. Patients with pre-existing ulcer or those receiving corticosteroids are at increased risk. Any kind of circulatory compromise, including reduction of cardiac output caused by PPV, may contribute to ischemia of the gastric and intestinal translocation of GI bacteria. Stress ulcer prophylaxis includes the administration of a histine receptor blockers, proton pump inhibitors, and/or enteral nutrition to decrease gastric acidity and diminish the risk of stress ulcer and hemorrhage. The use of PPIs may be linked to stress ulcer and hemorrhage. The use of PPIs may be linked to an increase in the development of Clostridium difficile-associated diarrhea. As previously stated, the patient receiving mechanical ventilation often experiences physical and emotional stress. In addition to the problems related to the critical care patient discussed, a patient supported by a mechanical ventilator is unable to speak, eat, move, or breathe normally. Tubes and machines cause pain, fear, and anxiety. Usual activities of daily living, such as eating, eliminating, and coughing, are extremely complicated. At times, the decision is made to paralyze the patient with a neuromuscular blocking agent, such as pancuronium or cisatricuronium, to provide more effective synchrony with the ventilator and improve oxygenation. Remember that the patient can hear, see, think, and feel. It is essential to give IV sedation and analgesia concurrently when the patient is paralyzed. The train of four, or TOF, is peripheral nerve stimulation used to monitor and titrate the patient's paralytics and sedation based on the patient's nerve impulse reaction. The goal is to avoid mechanical ventilators may become disconnected or malfunction. When turned on and operative, alarms alert you to problems. Most deaths from accidental ventilator disconnection occur when the alarm is off. Most accidental disconnections in critical care settings are discovered by low pressure alarms. The most frequent site for disconnection is between the tracheal tube and then twist to secure more tightly. Be certain that alarms are set and active at all times and chart that this is the case. You can pause alarms, not inactivate, during suctioning or removal from the ventilator, but you must reactivate them before leaving the patient's bedside. PPV and the hypermetabolism associated with critical illness can contribute to inadequate nutrition. The presence of an ET tube eliminates the normal route for eating. Patients with a long-term tracheostomy may be able to eat normally once the stoma heals. Swallowing studies and a consultation with a speech therapist are done to assess the patient's readiness. When eating with a tracheostomy tube in place, the patient should tilt the head slightly forward to facilitate swallowing and to prevent aspiration. Diet may be restricted to soft foods such as puddings and ice cream and thickened liquids. Weaning is the process of resuming spontaneous breathing. The weaning process differs for patients requiring short-term ventilation up to 3 days versus long-term ventilation longer than 3 days. Patients requiring short-term ventilation, like the patients we just talked about who have had cabbage surgery, will experience a linear kind of weaning process. Patients likely to require prolonged positive pressure ventilation, such as patients with COPD that develop respiratory failure, will often experience a weaning process that consists of alternative gains and losses. Preparation for weaning begins when PPV is. Weaning generally consists of 3 phases: the pre-weaning phase, the weaning phase, and the outcomes phase. The pre-weaning or assessment phase determines the patient's ability to breathe spontaneously. Assessment in this phase depends on a combination of respiratory and non-respiratory factors. Note the resolution of the primary problem. Patient's lungs should be reasonably clear on auscultation and X-ray. Weaning assessment parameters should include criteria to assess muscle strength, which consists of measuring negative inspiratory force, and endurance, which is spontaneous tidal volume, vital capacity, minute ventilation, and rapid check breathing index. I've already mentioned spontaneous awakening trials and spontaneous breathing trials as recommended for patients who meet a daily safety screen. This is all part of that ABCDEF bundle for ventilator management and a part of the weaning process. An SAT should be done by and a part of the weaning process. An SAT should be done by stopping all sedation and in patients without active pain, all opioids. Sedation should be restarted at 50% of the previous dose in patients who fail the spontaneous awakening trial and remain off in patients who pass awakening trial and remain off in patients who pass. A spontaneous breathing trial should be at least 30 minutes, but no more than 120 minutes. It may be done at low levels of CPAP, low levels of pressure support volume, or TPs. Tolerance of the trial may lead to extubation. For signs and symptoms that may signal a need to end the trial, such as tachypnea, dyspnea, tachycardia, dysrhythmia, sustained desaturation, that's an SpO2 less than 90, hypertension or hypotension, agitation, anxiety, diaphoresis, sustained tidal volume less than 5. Record the patient's tolerance throughout the weaning process and include statements regarding the patient's and the caregiver's perceptions. The weaning outcome phase refers to the period when the weaning stops and the patient is extubated or weaning is stopped because no further progress is being made. Patient who is ready for extubation, hyperoxygenation, and suctioning. Loosen the ET ties or commercial binder or the tracheostomy ties. Instruct the patient to take a deep breath and at the peak of inspiration, deflate the cuff and remove the tube in one motion. After removal, encourage the patient to deep breathe and cough, and suction the oropharynx as needed. Give supplemental O2 and provide nasal oral care. Carefully monitor the patient's vital signs, respiratory status, and oxygenation immediately following extubation within 1 hour and per agency policy. If the patient does not tolerate of a non-invasive ventilation may be necessary.